We'll directly go to the next talk by Dr. Elankumaran on my style of doing it. Over to you, sir.
I stand between you and the lunch now. After great talks by 5 people, actually I had to remove some of my slides there. Many of them were repetitions, so I removed, and maybe that's why Sony gave me this topic, my style of doing it. Thank you, Dr. Sony. Thank you, KSOS. Thank you, Dr. Srini, for giving me this opportunity. Let's remember nowadays that when we give a presbyopic solution, it's not just 6/6 that we are looking at. It has to be good vision. It has to be good vision for all distances, near, intermediate, intermediate, and distant intermediate and far. Not just 3, but there are 5 different distances that we work. But most importantly, there should be good quality of vision. This is what everyone was talking here. Now, how do we decide on a monofocal? Initially, we started with high-add monofocals, which were concentrating, bifocals rather, which are concentrating on near, and then we shifted to low-add monofocals, which slowly shifted the distance. Multifocals, which slowly shifted the distance. Now, all these has been spoken about by my previous speakers, so I would just like to add a couple of words. Counseling. If there's one thing that will bail you out in any particular situation, it is the counseling. So, the chair time the surgeon takes with the patient is directly proportional to the satisfaction, assuming that all other parameters are normal. Look at the tear film quality and the MGD. Commonly we miss in a large OPD. Definitely we miss this. We just keep looking at the lens. But there is a subtle tear film quality deficit. Maybe it's just a blinking deficit wherein the patient has to be taught to blink, or it could be an oil deformity where the adequate treatment has to be given, or it could be use of lubricating drops, stabilize this particular patient, and only then take him up even for calculations. Keratometry. How do we go about the keratometry? Very valid point what Dr. Meenu was talking about, a patient in, he mentioned everywhere, he forgot to mention Bangalore. Now, Bangalore is a place where there's high expectation, but always, it's not 80% insurance, it's 100% insurance, almost 98 to 100% insurance. They expect us to do everything within that. So, any keratometer that you have been using for your monofocals, I'm sure all of us before going to multifocals or trifocals have used at least 200 to 200 monofocals at least. So, any keratometer that we have used, optimized, is good enough. Coming to the topography, is it good? Answer is no. Do not use the SIMK values, particularly from a pentacam, to calculate the IOL power. So what is this good for? We will show it later. It is to show the generalized structure of the cornea, to look at, if you don't have any other equipment, to look at angle alpha and angle kappa, and also to look at the higher order aberration, just to give a hint, and maybe confirm the cylindrical axis. This is what this pentacam or other topographers are used for. Best for keratometry is to use the optical biometer itself. Go for the best optical biometer that you can afford. All of us here started off with the old ultrasonic biometer. I still have my 21-year-old EchoRule 2, which I had shown in my previous presentation. Still working, still good enough if it is done by me. So remember to do the biometry by the surgeon himself, or at least the senior most optometrist who has been trained by you. The same thing holds good for a counselor. Counselor should be sitting with you for at least 100 cases and then start counseling separately. Use the best of the formulas available. The best of the formula is also free. Remember, both Barrett, Hill RBF is available free on the website. Utilize that opportunity even if your machine doesn't have it. If your machine has it, great. What Dr. Mohan Rajan says, I always advocate in the practice. All my cataract patients go through this macular OCT. It happened after a patient where it was just a monofocal IOL, very dense cataract, missed out a macular edema. Macular edema, very small BRVO macular edema, we had missed it out and we had to go through a lot of problems with that particular patient explaining what had happened. So, the newer OCT, SS-based OCTs, have the potency to pick up macular pathologies even in dense of cataracts. So, please utilize that. Look for higher order aberrations if you have the appropriate equipment, and for the angle, kappa and alpha. Alpha more important in these cases. There was an excellent presentation by Dr. Anaga and the other thing, why alpha is better than. Now you have this printout in front of you. What do you look at it? Number one, look at that value, cylindrical value. Now you will know why I have chosen this particular biometry. One is 0.45, another is 1. Dr. Mino clearly mentioned, when it comes to monofocal IOL, we can have a cutoff of 1 dioptric cylinder, but when it comes to multifocal IOLs, trifocals, EDOFs or others, my cutoff is anything above 0.5. 0.75 is what he said. That's what we do. Anything above 0.5, treat the cylinder. Now next, look at this graph. That should have been first actually. The graph should be proper. I'm not going into the details. The next thing what I look at is this particular thing. This is the macular point. Is it sharp like this or is it blunted like this? Blunted may not necessarily mean a pathology, but is indicative of a pathology. Look for it. Next, come down, look at this IOL power. Compare it between the two eyes and compare it between multiple formula. Now herein comes the concept. If you have 2 biometers, please use those 2 biometers. Minu was telling 3. He has probably 3, or probably he repeats 3 times. But at least repeat it, or if you have 2 different biometers, please use those 2 biometers, use multiple formulas. Deliberately, I use the slide of KSOS president. If given a choice, which formula to use, the higher the variables the formula uses, the better the formula is. So obviously, you will know that the 5 variable and the 7 variable formulas are better. 7 variable holiday 2 is not freely available online. It's available only to IOL master users, but Barrett 5 variable is available. Now, what do you see on a pentacam? Again, I reiterate, don't use these SIMK values. The first one, don't use these SIMK values. But what you should see is this. Is it regular? Are there any areas which probably your optical biometer would have missed out? Look at localized areas of thinning and then look at those values to note the angles. Anything more than 0.4, I would not use. Finally, again, this should have been the first thing to be seen, whether this particular pentacam has been taken properly. The simplest thing is to get a cataract, if you don't have a pentacam, to ask your friend to send you a cataract workup and look at these values. Along with that, look at the aberrations. The front surface of the cornea produces the maximum aberrations, but sometimes, look at this higher order aberration. It will definitely be different. So take the total corneal aberrations, particularly in cases of refractive surgeries, and then go ahead with it. EKR value, I don't want to go too much into this, paucity of time. Just make sure that this particular graph is tall, sharp, not scattered to have the best of the results. Again, I reiterate, an OCT like this looks very much normal, but there is one particular sign we have to look for, V to U sign. The macula, there is something. This is early age-related macular degeneration. Warn these patients. Not that I do not avoid multifocal or trifocal in these patients, but I warn them and prefer to go with premium monofocals or enhanced monofocal. Look at this angle. Okay, we don't have a eye tracy. How do we go about it? If you have a pentacam, utilize it. If not, IOL Master 700 also has this function. None of this is available. Even 20 years back, we knew this concept. Only thing we were not applying it. How were we doing it? Just throw a torchlight. Look at where it is reflecting on the cornea. You will have a rough estimate. May not be a proper estimate, at least a rough estimate. Something like this, utilize. You can go ahead. The first one, go ahead with the multifocal. The second one should not be. I'll make it fast, sorry. Intraoperatively, Dr. Minu Mathan showed a video. What I would like to emphasize, complete overlap of the rexes. Make sure that the 2 Purkinje images also overlap, and always place this lens vertically so that you can make a little bit of nudging movements towards the nasal side if necessary. Now, how do I differentiate? I don't want to go into the brands. I don't want to go, all the technology has been spoken about. In fact, some of them, some of his slides have to delete.
Yes.
Avid, last slide. Avid, just one more slide. Avid reader, trifocal, otherwise EDOF. Safest bet if you are starting off, enhanced monofocal would be better. How do I optimize between the 2 eyes? Always operate the non-dominant eye, either on target or 0.5 myopic. 0.5 myopic if I'm using enhanced monofocal, and then use that optimization for the dominant eye. Thank you, KSOS. Thank you, Dr. Soni. Thank you, the scientific committee for this opportunity.
Thank you, Dr. Ellen, for that summing up of the whole talk.